The idea for today is to give you an overview of our national health system, how it works, how it's financed, how it delivers the care to the people. However, I always consider that it's quite important to know how we come here, how we come today. So I'm going to start the presentation. The first part is going to be give an overview of our country current health profile, the major statistics about not only health but also our way of living in general. Then I'm going to give a brief introduction of how we came to how is today our health system, a little bit of the historic perspective. I'm not going to go deep into that, but I think it's quite important to mention it. And then I'm going to talk how the system is currently configured, how it's financed, how it's managed. And then I think we can open a space for exchange and questions that you may have. I was talking with your professor, and she told me that this is the first of the several visits you are going to have during this tour. So please feel free at the end of the presentation to make any question you have, and also I'm going to try to give you a perspective of all the different things you're going to encounter during this visit, but in case you have any other question, I can give you my contact details at the end to, if you want to go any further in this discussion we are going to have. A second, please. I think I'm going to be speaking around 1 hour, 10 minutes, but in case you want to stop in the middle way, we can do it. Okay. As I mentioned, just a perspective, you can see Costa Rica is a very a very small country. We are just in the middle of Central America, between the two continental masses of North America and South America. You will see that in such small country there is no much room for diversity, but we are one of the most diverse countries in the world, both in terms of national diversity. We host 5% of all different species of plants and animals on the world, and we are very, very small, but we also have some cultural diversity and people diversity that's interesting to explore and understand, because also that implies some major challenges for our health systems. In total, sorry, I don't know how much is that in square miles or the measure used in the US, but I can tell you that in terms, we can be compared to the size of Rhode Island, that is the smallest state you have in the US. We are divided into 7 provinces that, different to what happened in the US, we are not a federal country. We're just a unitarian country, so the regulations that are set at national level apply to all parts of the country, and we don't have like a sub-regional level. We don't have like a governor or any kind of structure. So for national level, we go directly to municipalities. Oops. Yeah. ¿Cómo estamos con streaming? Okay, we're live still. So we go directly to municipalities that they don't have the same level of autonomy you have in the US with your local government. So we are mostly a centralized country that everything depends on the rules that are set by the national government, both the executive and the legislative branch. Our capital city is San Jose, our council Colón, our official language is Spanish across the country, but we have some influences of other languages in the Caribbean with English and Patois. It's a variant of English, Caribbean English. And also we have the indigenous language of different ethnic groups across the country. Our GDP estimate per capita is 17,930 US dollars for the year 2018, which gives us a position of upper middle income country. So we're not a poor country, we're not a limited income country, but the amount of inequality makes that not all the people access the same amount of income across the country. We have several differences, very strong difference between the center of the country, or everything surrounding the Central Valley and the capital, and the population on the coast and the borders, who actually have a lesser level of income and quality of life. Okay, our population was around 4.8 million a few years ago. Now we are actually in the process of the new census for this period. It's actually being taken currently, and it's estimated that we are past 5 million currently. Our composition of ethnicity, most of the people in Costa Rica is white from European descendants, specifically Spaniard, but we are like, this is auto-perceived ethnicity, so there is a lot of mixture. Maybe it's not remarked, you can see in other countries on the region, that you're going to see most of the people is like light white, or light, not as dark as you see in other places, but we have like many Caribbean, black Caribbean influence, both in the Caribbean and in the Atlantic, and also some in the Pacific coast. You know, the different Aboriginal or First Nation ethnicity we have in different parts of the country. As I told you, we are the diverse country. There's just a mixture of the different scenes you can see. For example, here on the upper side is the influence from the North Pacific, the Guanacaste province. Many of the traditions about dance, food that identify the country comes from the area. But we also have the culture of downtown, you can say there, from the metropolitan area of the Central Valley, that was forged around the coffee and the coffee culture. That doesn't, you cannot find it other places in the country, because the coffee is a crop that actually depends of certain specific temperature and altitude level that you cannot find on the coast. Here, huge sphere, it's pure stone, and it's actually comes from the south of the country. It's inheriting from a lost culture that we have not much information. This sphere was actually discovered around 100 years ago, and this culture abandoned the country around 1,000 years ago. So we don't know much of that, but it's very particular from the south. And this is just, you could go to any museum, you will find it just huge. They weigh like 5 tons, and they're perfect stones, perfect spheres, 360 degrees, made out of stone, one single piece. Nobody knows how they made it. Nobody knows about their function. It was ritualistic or whatever, but it's there. It's part of our inheritance. And all I mentioned the really strong Caribbean culture influence in the Atlantic province. So you can see, very small country, but lots of diversity there, culture and national. In terms of access to general service, electricity, safe water, sanitation, actually we are one of the most safety countries regarding the sanitation of water. So you must be completely, you can rely completely, you take water from the tap. It's not going to hurt you or harm you in any way. It's very safety, and you are actually going to save a lot of money not buying water from the bottle industry. The coverage of electricity, it's very high. Practically all the country is covered with electricity. Literally, in people over 10 years old, it's around 95%. And we don't have many problems about people living or overcrowding the houses. Okay, that's just a little bit of perspective so you know that, as told you, we are upper middle income country. According to certain forecasts of people who know who knows a lot about economy, Costa Rica could become an upper income country within the 15 years. We have to review now that after the pandemic, but the thing is that Costa Rica is in a better social economic position compared to other countries. And that's something that is important for you to know, because that actually influences a lot of what we are going to see here about our health status. That is also quite particular compared to other countries in the region. And also because that also puts a lot of pressure and different challenge to our current health system, because our disease, you are going to see, are more comparable to what you face in the US that we can compare to other countries in the region. So actually I mentioned a little bit of that. First, it's important to know that Costa Rica scores really, really well in terms of health. Okay? Even compared to other countries have a higher income or higher level of living, we have better results regarding certain indicators. I'm going to talk a little bit about that. But even compared to the US, for example, if we go to WHO statistics, the US usually ranks #1 in terms of health expenditure. The US is one, not even because of the size of the country, but comparative analytics. The amount that is spent per capita in the US is by far higher than any other country in the world. In Costa Rica, we rank 50th, so we spend less, far less in health expenditure, but the way we spend it makes a really important difference. Just taking one of the most analyzed indicators in the world, that is life expectancy at birth, you can see this figure here that we compare Costa Rica with other Latin American countries and the countries from the OECD. That is an organization, you know, that groups the country with the highest income in the world. And you can see there that compared to the Latin American country, that is the blue line, and we scored, Costa Rica is the red line, significantly higher. So that means that people in Costa Rica tend to live longer, and you could say even healthier than most countries in Latin America. And when we compare it with the countries with the highest income in the world, you can see that across the different decades, we are right now, even in certain period, even higher. So Costa Rica tends to live longer than most many people in the world. And I want just to clarify something here that is quite important. Maybe you already know, but it's not bad to remember, that this statistic is life expectancy at birth. So that means that people who were born in a particular year, how many more years they are expected to live in general, as an average. So this statistic, for example, in 2013, that the countries was practically 80, 79 point whatever years old. That means that people who were born, those children who were born in 2013, they could expect to live till 80 years in average. But what happened with this is that this is a particular statistic that changes depending on the moment of your life. So when you get a little longer, you actually are expected to live even a little more, to add some years. So there is another statistic, another indicator called the life expectancy at 60 years old. So people who is currently at 60, how many more years they are expected to live? And usually it's a little higher. And when we take this indicator and we compare Costa Rica to other countries, well, actually Costa Rica is it's on the top 3 countries in the world of seniors who are already 60 can actually expect to live even like 25 years more, so reaching to 85. And we are, in this indicator in particular, comparable to Japan, and I think Barbados or Bermuda is the other country in the world who actually tops with that. And when we take this indicator to 80, so people who is currently 80, they actually can expect to live around 7-8 years in average. So there are people who live longer. And actually at the end of the presentation, I'm going to give you the link to a really nice video that you can actually get into deeper about that explores the longevity in certain areas in Costa Rica. And the good thing about that is longevity, living a very healthy lifestyle. People who reached even 100 and living in a very good state of health. This is the demographic chart comparatively across the different decades. You can see on dark blue, that was, and you can see on the background, that was our chart in 1950. It was a traditionally pyramid that is like typical presentation that you find in young population. When you have many, many children, a very few senior, and a relative middle proportion on the young adults ages. That means that there is a lot of mortality in younger ages because especially children do not manage to overcome, especially 5 years, because of different diseases, infectious diseases, poor sanitation conditions, wherever. So the possibility to reach higher ages is really small. People will die neither in their early childhood or across the adult life. That was our situation in 1950. So the country at that moment, they have a very strong health system. We depend a lot of basic production of crops, banana mostly, and coffee in some sense. And in general, the people were really poor at that moment. So we gave a 60-year leap, to 2010, and you can see the light blue, a huge difference, especially on the younger areas. So we have narrowed down. In those 60-year area, what happened? Well, the health system got stronger, access to contraception services got stronger, education got stronger, so women decided to use those contraception methods that were available. They prolonged the age when they have the first kid, and they decided to downsize the family. For example, in my family, in total, I have around 21 uncle and aunts, both from my dad's and my mom's side. 12 from my dad and 8 from my mom. And that's the reality for most of the people of my parents' ages, in their 70s. They have huge family, around 8-10 kids. Most of my generation, those who were born in the 1970s, we downsized. Our parents took the decision, and it was like most common between 3 or 5. And now, people my generation, for example, I have many friends. I don't have kids. I'm 42. I don't have any kids, and probably I will not have. But many of my colleagues of the same age, or my relatives of the same age, they have like maybe 1, 2 kids. So that's something that impacts definitely our health needs. And as you can see, the amount of people living in senior ages, for example, my parents and my uncles and aunts, are getting like a wider percent of the population. And for 2035, using 13 years, you can see the difference that we are going to have less and less children, and we're going to have more and more seniors. Pretty much the same thing that you are going in the US right now. And for the year 2050, that's going to be completely different. When I become a senior, we are going to particularly be majority here. So that's going to demand a lot of care. And usually when I tell my students that that's a huge challenge, because when people say that in 2050 we are going to be a lot of seniors, and they say that we have to prepare for that, I agree completely. They think that we are going to start preparing for that in the year 2049. We were already or neither too sick or too disabled to do anything. I would say that we had to start preparing for 2015 today, because we who are in our middle age, still relatively healthy adults, we should start actually caring for our healthy life then, today, by adopting from since today the healthy lifestyle that actually we assure us a healthy lifestyle when we become seniors. A little bit of what I have told you, some specific numbers. The birth rate per woman, in general, birth rate per 1,000 inhabitants, it was 14.85 for the year 2015. This statistic is a little bit old because I told you the current census is taking place today. I was supposed to be taken on 2020, but you know what happened in 2020. And we are taking a 2-year delay on the census, so we are going to have like fresh statistics by the end of the year. Death rate, it was 4.35, but I want to stress in this infant mortality rate, it's 7.76 for the year 2000. It's still quite high you compare it to the US and other high-income countries like Europe or Canada or Japan. However, most of the death you see there is from life conditions that were incompatible to life. There are kids that were born in a matter of hours because they were born without a brain or a severe heart condition that once they abandon the womb of their mother, they die. And that's a statistic that cannot be avoided with the current status of state-of-the-art medical technology. In many other countries, what happens is that those kids, they are not even born because the pregnancy is terminated in early stages when you can see that the fetus is not going to be compatible with life. Here, because of legal reason, that's not allowed, so those children had to be born, and of course they die. And of course there are some children that they die because diseases that they are contracted within the community or other aspects, but they are minority. And in terms of maternal mortality, it's really, really, really low. So the amount of women that died because of conditions related with the pregnancy is extremely low. So that's actually very good because that means that these women have access to proper medical care since the moment they actually learn they are pregnant. And okay, HIV, the amount of people who currently it's dying for HIV, it's minimal because we have access, universal access to antiretroviral drugs for everybody who is in that condition. So nowadays, as many other parts in the world, people actually never develop AIDS. They live in a chronic stage of HIV positivity. Since last year was, or 2020, I don't remember, we have like PrEP, PrEP, therapy. They're like a preventive drug for people who can use in order to not get infected or to maintain the levels at zero once they are infected. So right now, HIV is a chronic condition. It's not a lethal condition as it used to be in the 90s or the 80s. The causes of death for people in general, this includes everybody who died in the country. You can see 79% of people die from non-communicable diseases like chronic diseases, cancer, diabetes, high blood pressure, things like that. Sorry. External causes is the second major group, and that goes specifically to road injuries, people who die of car crashes or they're hit by cars, bikers, things like that, or also gunshots or trauma in general, violence, murders, things like that. 7% are communicable diseases or diseases related with infant and maternal death, and as I mentioned, it's really, really low, or nutritional causes. And 3% is unspecified. And it's quite important also because this gives you a perspective of how good our national statistics system works. In Costa Rica, it's not legal to bury or even cremate or dispose anybody of a dead person if you don't have a proper medical certificate that actually states the cause of death. It's not necessary an autopsy. Autopsy is always necessary. You're going to cremate a body, but you cannot go to a cemetery or any other facility unless a doctor, a certified doctor, can issue the certificate of the cause of death. In other countries, even here, like 50 years ago, anyone with authority, like a police person, could just sign the paper and just go to the cemetery and dispose the body. But now it's not legal. So that actually gives you a strong credibility of the statistics about death causes. I'm not going to read there. I can facilitate you later the statistics, but you can see some of the indicators I had mentioned there, how we score. Especially the first one that is regarding, for example, child immunization for this vaccination DPT on the third dose is quite high, over 90 usually. This is the one that prevents measles, diphtheria, and tetanus. But the other ones like hepatitis, meningitis, tuberculosis, measles, chickenpox, yeah, we have all that kind of coverage, and we have also the vaccination of HPV. Sorry, I just trying to sing the definition of the different acronyms from Spanish to English, and that usually takes me some time. That is the one that prevents like cervical cancer on young women and adult women. We have it available since like 4 years ago. Okay, I was told that you care about a lot about how the system is financed, so I'm going to give you some statistics about that. It's quite important, actually. There's a say here, something goes like that, that without coca, there is no chocolate, in the sense that you cannot enjoy something if you don't have the resources, the basic resources to do that. So, of course, many people believe because we are a social system, like a national public system, money is not an issue, but money is really an issue, because we have to be very careful of how the limited resources we have is used. So our expenditure on health, and that includes public and private expenditure health, the gross development product, it's 10%. The government expenditure of that amount is 7.6. So you can see that around 75%, even a little more, of the health expenditure is public expenditure. That it comes from the taxes we pay to the government in different modalities. It will be to the Social Security through our payroll taxes, or to other different kind of taxes that we are paying to the government, for example, the tobacco control taxes and other sources of income that goes to our national health services. And the total, okay, this is to make the difference clear. Number one and number two is like the amount of money that everybody in Costa Rica spends, all our individual citizens, but also our companies, our institutions, the public and private organization, everybody who spend time in Costa Rica, all of that put together, 10% is related to health. That goes for all the salaries that are paying the doctors and nurses at hospitals, but also the money you spend, for example, in a drug store on your neighborhood. Okay, all of that money, 10%, is spent on health. 7.6, so 75% of all that money is spent by the government on our national health services. But now you take the whole budget of the government. That includes defense, education, sanitation, whatever. Around 27.7% that is dedicated to health expenditure on the public hospital, the clinics, and the different facilities that we have across the country that are owned by the state. Okay. I'm going to move a little forward. I think the statistics already covered it. Okay. So this is a general overview, of how much money we spend, and also how we are currently in terms of our current status. So how we come here, because as I mentioned, even we score very good and comparatively very good to our countries, even countries who have more money than us. That's not something that happened overnight. That actually was a long, long, long way. I'm not going to talk you since 200 years ago, but it's quite important to know that health has always been a priority for our leaders. We became independent from Spain in 1821. Those first years, those first 20 years was quite chaotic in the country because we didn't know exactly what we are going to do with our independence. At the beginning, we said we are going to be an independent country. Then we said we are going to be part of Central American Federation. Then we are going to be part of Mexico. Now we are going to be independent again. And we have a small civil war to decide what we are going to be. And finally, 20 years later, we decided we are going to be an independent republic, period. Okay? At that moment, the country was already quite stable. We elected our first president in 1945. He was named Jose Maria Castro Madrid. And at that moment, it was decided, so we are going to start building the country as its own, with having their own institution, its own organization. And he decided one of the first things he would do as a country, we should do as a country, and also as a free country, is to have our own hospital. So just figure out that we had been like working for 300 years at that moment as a colony of Spain. We didn't have a hospital or access to properly trained physicians. So he decided we are going to have a hospital. And this is part of the words he gave to the Congress when the budget and the plan to open the first hospital was decided. He said, the obligation of any government in a society is to watch over for the health of its people. Therefore, there is a need to open a hospital to study the main causes of disease of our country, an urgent need to open the medical science as a means to provide progress and comfort to the suffering humanity. No wise ruler shall ever ignore these needs. Consequently, I cannot possibly find better reasons to open a state's general hospital. So the hospital was decided to be open in 1845. It took several years to find the money and to build actually the facilities. And by 1851, yeah, 1551, the hospital opened. It actually is still the longest standing hospital. It's just right down in the center of San Jose. It's called Hospital San Juan de Dios, St. John's Hospital, and it's still there working. Okay, for many, many years, almost more than 120 years, it operates on its own as a public hospital that receive direct taxes, income from the government. And then in the 1970s, it was passed to the Social Security. It's still a public hospital, but now it belongs to the network of the Social Security. At that time, for over 120 years, it focused mostly on charitable work, in the sense that attend people with poor income, and they deliver care to that. As I told you, I mentioned this just to give you an idea that health was always a priority over the 200 years. Just giving another bit leap, 100 years after that, this person here, Dr. Solon Núñez, he was our first Minister of Health. The Minister of Health here was created in the late 1920s as a way to expand the service from the hospital to the different communities. So until that moment, we have some hospitals in the country, the 1920s, but only served like the metropolitan areas of San Jose. Then the ministry is created with the main goal to expand the services to the communities, not to open hospitals, but to open clinics and different facilities to actually reach more of the peoples. This person, Dr. Núñez, as I told you, he was the first Minister of Health. In 1948, when he was like old person at that moment, he was like ending his career. In an interview about all the work he did, created the ministry, he said something like that: "Today's medicine cannot, must not be an individualistic medicine. It is essential that our physicians understand that their main responsibilities are not single patients, but a whole society. The first representative of the state on a patient bed must be the physician." This is quite important because actually they tell a lot of how the system was configured from the 1920s. The 1940s when was the main reform that actually configured our current health system till today. Because actually give you a perspective that, as mentioned, health is a responsibility of the government, of the state, in the sense that we are not like, you could say, like a socialistic, communistic system that used to be in the 1960s or 70s in some parts of the world, but it's saying that health is a people's priority in general. So the state had to take all decisions, all the procurements to actually ensure the people becomes or remains in a healthy condition. And that's why actually the whole system is configured in a way to reach people. So actually go there not only to facilitate the hospitals for acute care or chronic care, but also reach people in where they live and where they study and where they work. I'm going just to refer this to these three people because they are quite important in our history. The first one is Dr. Rafael Calderón Guardia. He was president of the country between 1940 and 1944, just the period of the Second World War. And it was a very chaotic period in the world, of course. And what happened is that he became president at that moment. His personal experience is quite interesting. He was the son of another doctor, but he was coming from a very rich family, very rich family. At that moment, when he was a young man in 1920s, sorry, there was no med school in Costa Rica. So most people have the option to go to Mexico or to Chile to study there. You have like a wealthy family, but you have a really, really, really wealthy family, you go to Europe. So he came from a very wealthy family. He studied in Belgium, which was quite expensive at that moment. Being in Belgium, he get acquaintance with many people who were leading the social reformation of medical care in Europe, especially the ideas coming from Germany at that time, from the Bismarck, the Chancellor Bismarck, who created social security movement as we know it today. He got acquainted with that. He got acquainted also with the social movement of the Catholic Church at that moment, who were calling also to do those kind of reformation, to create systems to finance. Also, that's, I think it's quite important to have in mind. The social security is a financial movement at the end. It's a way to gather and pull in economical resources to assure that the people will get cover and will have actually the means to cover their basic needs of life, unemployment, health, ancianity, disability, without going into poverty, because that's a general, a social issue of the country, because we all contribute to that and we pull the resources to finance that. So he got acquaintance with all those ideas. He really got sensibilized, and he said that one day when I become a doctor and go back to Costa Rica, I had to do something to actually got all those ideas to benefit our people. So he became eventually a president, and as I told you, he was coming from a very wealthy family, so all his friends, all his relatives were also very wealthy people. So he became a president, and he said, you know what, I want to do this. This that is being done in Europe is being done in France, in UK, in Germany. So they're developed countries, they are state-of-the-art countries in terms of mentality, so why we don't do the same here in Costa Rica? And the answer he got from his peer was, no, that's quite expensive, and I'm not going to give any money to do that. And he told also, well, my peers are not going to tell, to listen to me, so I'm going to talk with my colleagues, with other doctors. And he said, like, hey, why don't we create a social security or public services to live everywhere? And they say, no, because we are going to lose business. We are going to lose our private practice, and we are going to lose our incomes, and we are going to become employees of the state. So no. So he faced a lot of resistance. So he said, okay, my colleagues, my peers say no, so let's talk with our enemies. Let's talk to the Communist Party. But we cannot go just directly to the Communist Party, so we should get someone who, like, be the middleman, the wingman, and let's go and speak with the church. So this unlikely alliance between the rich doctor, the young priest, and the young communist became a thing. He said they actually gathered together, these three guys you see there, Dr. Calderon, Mr. Manuel Mora, who was the leader of the Communist Party. He was actually trained as a communist in the Soviet Union at that moment. And when he came to Costa Rica, he said, yeah, I want a Communist Party here, but I don't want a copy of the Communist Party in Russia, because we are not Russians, we are not Europeans, so we are going to create a Latin tropical version of the communism that actually cares for people, not for the rulers of the Communist Party, which was actually what was happening in Europe. And we have this guy, the young priest who became bishop at a very young age, who was also very aware of the social reformation of the church, but he said, like, I'm a Catholic, so I had to protect the church interests, so I'm not going to become a communist neither. But they start together, working together, talking together, and they have like this idea, okay, we are very clear on the things we disagree, and we are not going to change any one ideology or mentality on that. So I'm going to keep being a rich doctor, you're going to be praying your rosaries and performing your masses at church, and you're going to keep being a communist. But what things we agree? And one of the things they agreed was creating the first regulation for labor laws, actually give the foundations for the minimum wage, the minimum working hour, the maximum working hours, the annual pay leave, and things like that. And one of the other things was creating the Social Security. So in 1941, the Social Security was created. The institution still works today. It's the major provider of healthcare services, but also the major provider of the pension funds and other facilities and benefits that the people of Costa Rica enjoy. Last year we celebrated the 80 years of the foundation of that institution, and they're still there. That was at the beginning of the 1940s. It happened that he abandoned the power in 1948. A new president came. We have elections again in 1948, and there was a huge scandal at that moment because accusation of fraud was made, and the worst thing is that they were real. They actually had been fraud in the government. And there was the same party that took Dr. Calderon to power. So we have a civil war at that moment. The guy who lost the election officially, but who had actually won in real life, he won the war, and he became president at that moment. And there was a lot of oppression to that guy, who was this guy here, Mr. Jose Figueres. Once he won power, he became like a soft dictator for a couple of years. And there was a lot of pressure to people to say, look, now you're in power, you're from a different party, you're from a different ideological background, so get rid of all these reformations the communists and the Dr. Calderon did, because it's bad for business, it's bad for the economy. And instead of doing that, he said, like, you know what, no, I agree with that. I agree that the country must have some stability, some social institution that actually will provide benefit for people. So he not only remained all the reformation, in certain aspects, he made them stronger. And he actually, one of the things, the most important thing he did in December 1st, 1948, is to abolish the army. In the sense that there was, of course, a political movement that saying that if we don't have an army, I don't have anyone who can actually make a coup, a dictator. Of course, he was a stupid guy. But that also give us some resources, because when you don't have an army, you don't have to spend so much money in the troops and weapons and other things, so we have more money. And the important thing is that with that money, the governments could have said that we are going to spend it in a stronger police force or a more beautiful headquarters for our ministers and our presidents and things like that, but they decided to invest it basically in two more major areas: health and education. After 1948, there was a huge amount of money to went into building schools and healthcare facilities run by the state. And that's quite important. Nowadays, actually, we always believe that that was like the breaking point in our history, abolish the army, because actually that changed a lot of our mentality. We were the first country actually in the world to abolish an army. Now there are a little bit more, but we were the first one. And actually that changed a lot of our identity as a country. You know, as mentioned, that also gave us a lot of resources. Nowadays, actually, since 10 years ago, that day, December 1st, was declared a national holiday. So you can hear it's Abolition Day. It's December 1st, and we have like way to celebrate that. Okay, I'm just going to go very quickly with this. After that, we have finally a national health system in the sense that we have institutions, we have an idea of how the system is going to be organized and how to be provide the services, and also how it's going to be financed. There are three major periods that I personally, from my personal studies, have come with the idea. We have a period, the first one, of development extension going from the 1950s to the 1970s, where the services just start growing up and up and up, and there was a lot of different strategies like missions. People get the doctors into cars and buses especially designed to provide medical care and visit different places, and people start like getting actually benefits from modern medicine. In that period, for example, one of the major strategies that happened was contraception, actually educating women to use those methods, and also sanitation was one of the major issues. Then it comes to the 1970s, and we start like actually seeing the first benefits of that reformation that were made on the previous stage. Is what, for example, what I mentioned, 1950s and 70s is when most of my parents' generation were born. So they were still like huge families. By the 1970s, when my generation was born, we were actually downsizing because of the better education the generation of my parents, especially my aunts, my mother, and all the women in that area, got from their reproductive health. So we were less kids, so we had more resources available, better access to education, even to higher education. That actually gave that period of consolidation to our health system. By 1970, you compare the people living, that were being born in 1970 to the people who were born in 1995, that were the generation of my nephews and nieces. They were completely different. Okay? People with better health condition, very well nourished, and different struggles at the time. And then comes the actual configuration of our system that is going from the 1995, that was the moment of the last reformation of the health sector, to the present. Just a very brief mention, but I think it's quite important. That period, I told you, that was the period of expansion, 1995, 1990. Many different initiatives, but one of them actually outstanding. It was called Hospital with No Walls. Well, it was actually a strategy led by this man here, Dr. Ortiz Gaia, who actually was a surgeon, a trained surgeon, who made a social service in a rural community in Costa Rica at that moment. Nowadays, it's a big city. But he realized that most of the health problems he was receiving at the hospital, he was wondering why people is getting so sick here at the hospital. Is there anything I could do to avoid people actually to come to the hospital? So he decided this strategy, who was called Hospital with No Wall, was basically taking all the health services, the physicians, the nurses, the technicians, into the communities to go to those places and actually see how people were living, who were people who are actually getting sick because they don't have access to food, to proper roads, to proper education. And he started like doing all this movement in that community called Hospital with No Wall. At the point that in 1978, and that picture is actually taken at the headquarters of WHO, he received a award to acknowledge and reward all the work he had made in the country. He was recognized by his peers in the World Health Organization. He said this at the time: through the program of Hospitals with No Walls, the communities organized themselves to find malnutrition, improved roads and aqueducts, to bring electricity to forsaken areas, and to assure that every child was vaccinated, as well to open farming cooperatives. So he saw we cannot have healthy people with the means to to do that without work, without proper education, without proper access to facilities. So it was quite interesting because he gave a broader vision of health, not only health care or disease care, but health in general. Okay. I just want to mention that because it's a very important thing of our history. Okay, now we're getting closer. This is the current configuration of our health system. Sorry, it's in Spanish, but I will try to explain a little bit. What happened in 1995 is due to a series of different political decisions and also to the international context at that moment. Until this moment, we have like two major public providers of healthcare services. We have the Ministry of Health on one hand and the Social Security in the other hand. What happened in that moment is that the ministry was in charge basically of all the services of what we call the first level of care. So the small clinics or small consultation practices that were on the communities were taken by the Ministry of Health with their own doctors and nurses, and we have the Social Security that provide mostly the specialized care on their hospitals and major clinics. At that moment, it was decided by the authorities, by the Congress and the minister and the president, and also because of some ideas that come from the World Bank, that was not very efficient, that we should concentrate all the public services in one institution. That was the Social Security. And the Ministry of Health should deal with all the public health services, what we call stewardship, in setting the national policies and the national plans, the regulations, dealing with disease control in terms of epidemics, outbreaks, things like that, and regulate or oversee the provision of health services that is being done by the Social Security and also by the public, by the private sector, that at that moment was not big compared to the Social Security, but was starting to grow. And nowadays, actually, it's still not as big as the Social Security, but it's getting stronger and stronger, and I'm going to explain why. So currently, this is our configuration. We have a minister or a Ministry of Health, led by the minister, who is appointed by the president every 4 years when we have a new president. I don't know if you know, but we are actually, we have a brand new government take office only 2 months ago, in May 8th. So we have new authorities after the election process we have in February. Of course, there are times that the president changes minister during his term. New president, new minister have to take charge of the institution. Like 4 years, no, that was before the pandemic. In the previous government, we have 4 Ministry of Health, 4 ministers of health in a period of 4 years, practically 1 per year. And the role of the ministry as an institution is to implement the strategic direction, regulate providers, enable epidemiological surveillance, and steer the direction of research and technological development. That's the official mission of the ministry. So it's like, as mentioned, the steward of the whole system, both the public and the private sector. And also is responsible to collect and distribute the money for certain health services, especially vaccination. So it works this way. The Ministry of Finance collects the money from general taxes. They pull them in the national budget, and they give that money to the Ministry of Health. So the Ministry of Health, through the standard mechanisms that are defined to do that by the vaccines, and they gave the vaccines to the Social Security, so they will be provision those vaccinations to the kids or to the old elderly through their services. The vaccines that are purchased through this mechanism is basically all the vaccines for the kids, and certain for elderly people, for example, influenza vaccination, and for example, also the vaccination for HPV that I mentioned before. All of that is, are purchased by the Ministry of Health, but they are provided, the vaccine, by the Social Security. In, for example, COVID vaccination, the money came from the National Emergency Fund, because COVID, since was declared a national emergency, there was no money allocated in the general national budget for that vaccination, but we were able to purchase the vaccination just in time, as soon as they were available. Actually, the vaccination campaign started in December 24th, 2020. It was like the Christmas present that the government gave to the people that year. And only because we have enough money coming from the emergency fund to make the negotiation with the different pharmaceuticals at the beginning of the pandemic. Okay. And part of the issues here is that the Ministry of Health, as mentioned, had to care with the stewardship not only with the health service providers, like hospitals, clinics also, but had to deal with everything that can affect health. For example, sanitation, air pollution, water disposal, sewer disposals, garbage disposals, work-related health issues, everything that can damage or affect possibly health of the people had to be overseen by the ministry. So we have a very comprehensive role of the ministry. Actually, one of the things that allowed that the country perform relatively very well during the pandemic was because we have a very good tracking system positive cases that was taken in charge by the ministry, not by the Social Security or the hospital, but by the ministry and all the trained colleagues I have at the ministry that deal with this matter. That actually gave the tracking not only to give the isolation orders to make people remain on houses, but also to do the planning and organize the different institutions, for example, the police or the border control and things like that, that actually allowed to have really comprehensive management of the pandemic, not only healthcare service provision at the hospital. And also it was quite important because due to this and to certain decision that was taken by the president at that moment at the instance of the ministry, for example, every time you had to go into isolation, because you were contact positive, a positive person, or even you were under suspicion because you were close contact of someone, you can get a paid license to remain in the house and not to leave to search for job or any other necessity you have. Even it was like a very well organized. Even cases like, for example, you have the means to isolate in your house because you were living together with other 10 people in your house, or you were like a migrant worker who come here, you can get like proper provision of services in hotels or other facilities that were covered by the government. And that was because we have actually very strong Ministry of Health that have the means to provide that. that's, I think, one of the advantages that we have an institution that deals only with the public health issues, and not compared to other ministerial health of the region, that they have to focus mostly on providing healthcare services for the poor people. That's actually the role that most ministries of health have in Latin America, to provide healthcare services for poor people. And all the aspect of public health is quite neglected. So here we can focus on that. Okay, healthcare. As I mentioned, the main provider of healthcare services is the Social Security institution called Caja Costarricense Seguro Social, Costa Rican Social Security Fund. We call it La Caja for short. It's the main insurer and the main provider, and this is quite important because it has a dual role. It collects the taxes coming from the payroll, and also it has its own facilities and its all healthcare personnel to provide the services. How it's financed? So from our payroll, all the workers we are employed by someone. We pay from our salary around 11.5, I think. 11.5% of our gross income. That goes around half, like 5.5%, to the health insurance. That is meant to cover all our health needs, from basic needs, for example, prenatal care or general sickness, till if you need a heart transplantation, it's covered. Everything is covered by the Social Security within the, of course, reasonable limits. You're not going to, for example, pay like, for example, you're not going to pay for plastic surgery, in case, for example, a woman wants to enlarge their breast, but if you are in the need of reconstructive surgery after breast cancer, you can get that, because it's not plastic surgery, it's reconstructive surgery. And things like that. I mean, there is like a national definition of what can be provided and what cannot be, but the list is really, really, really extensive. So the Social Security collects the money. I told you 5.5% from our income, our monthly income, go to this health insurance, public health insurance, and 4% goes to the pension fund. So when we reach 65 years old, yeah, currently, you can get the pension from the Social Security. There are other facilities, for example, private facilities. You can make savings with banks, public and private banks, to have like a more, to have an extra pension if you want. But everybody here in the country have like, if you are a worker, you have the access to get a pension if you are part of the Social Security scheme that basically covers everybody. By law, it has to cover everybody. And then, besides that, what we pay from our payroll, our employer had to pay an extra tax to cover also the health insurance and the pension fund. So it's financed in a free way. The employee, the employer, and also the state from the national collection of taxes had to get some amount to also cover the expenses of the Social Security. It's not perfect because, of course, there are many people who don't pay taxes. They legally do that. They employ people without reporting to the Social Security, or they report less than they pay. Of course, there is no perfect system, but generally it works. And many, many people contribute from all the different perspectives. I mean, the Social Security is the institution in all Central America who have the highest budget. There is actually a joke that we made, because it's true, that the worst part of that is true, that if you compare the budget of some neighbor countries of the region, even Nicaragua, the total budget of the whole government is less than the budget of Social Security would have, for several millions of dollars. Just so you have the perspective. And also have some income coming from, for example, you are like independent worker. For example, you are an architect or an engineer or a lawyer who has your own firm, you work for yourself, you have no boss, you can contribute also to the system in order to be covered. So the system have different sources of income. And also receive some other extra income, as I mentioned, for example, vaccines. Vaccines are not paid from the budget, they are of the Social Security, they're paid by the Ministry of Health, but they are given to the Social Security. And also there are some extra sources, for example, the tobacco tax that goes directly to the Social Security too. Okay, I already explained this. So the healthcare services of the institution, it's organized in a tier level structure. We have the primary healthcare services on the base of the pyramid. That actually, we don't call it primary healthcare here. We call it first level of care. This is to make a distinction because primary healthcare for us it refers not to a specific facility, like a small clinic, but it refers for us to a strategy. A strategy that is meant to tackle the primary causes of death and disease. So going to the primary sources, the workspace, the living conditions, the study conditions, the environmental conditions. That's why we call it primary, because there are two primary sources. So we usually call it first level of care, primer nivel de atención in Spanish. It is basically comprised of a network of small and medium-sized clinics across the country. Sorry. I'm going to show you a detail in the next slides. And after that, the next tier is a regional and mid-specialized hospital or clinics that provide specialized services like surgery, internal medicine, OBGYO, sorry. I always struggle with the acronyms in English. Obstetrics and gynecology and pediatrics, for example. And then we have the high specialized national hospitals that we have downtown in San Jose. They provide really specialized care comparable to certain things you can have in the US, but they provide it to the whole country. Okay. This is like an illustration of the network of small clinics. We call it ABICE. That is like acronym for basic things of for primary health care. That is comprised with a physician, a GP, a nurse, a technician, and a secretary. The idea of this team, they are based in a very small facility. They only have like the doctor's consultation and the secretary desk and the working space of the nurse, is to provide care, basic care there on the communities. It's supposed not always happen that way, but in most cases, the clinic is within the community. And the idea is to provide care for around 4,000 people. There is not always it's that exact. Maybe in some cases 3,000, in some cases 5,000, but in average it's meant to provide care for 4,000 people. And that's we call it the getaway. That's the first contact you must have with the national health system. So when you have a problem that is not, of course, an emergency, you go there. You're woman who want to get contraceptive services, you go there, you get the provision, where it will be the pill or any other device that is available, or even you are a woman who want to get a surgery to not have kids any longer, you go there to get referral to the hospital who is going to perform the surgery and do all the analysis. Even you are also a person who have a headache or have a minor injury, you go there. Or you're someone who has been diagnosed with diabetes or high blood pressure, you go there to get your control and your medicines. Or you want to have like a general checkout, an annual checkout, you go there. The idea is to get the services near to the people, but also not only for the people to go there, but also the services go where the people is. I mentioned that there is a technician there, and that technician is what we call it the primary care technician. The role is go and visit every house within the jurisdiction and to see what people is needing there. For example, detecting early cases of people with high blood pressure, or kids who have not the vaccination scheme complete, or any kind of need that people can benefit from going to the clinic, or the clinic taking care of that, they take care of that. They also visit schools, sometimes they visit workplaces, especially where there are big places like factories. The idea is to approach not only the people to the services, but also the services to the people. Does it work perfectly all the time? No, of course not. No system is perfect, but that's how the system is configured. Many things, many places work in that way across the country. As I tell you, that was very instrumental also to deal with the pandemic, because this kind of structure also provide care for the people. For example, when someone was diagnosed with COVID, these services have the task to call every day to that person or to the person who was in charge of the care to see, how are you doing? Are you feeling well? You need more medication? I can send you through, actually to Uber, not Uber, but all the delivering services we have. They were sending the medications to the houses in order for people not to leave. And when they detect someone actually deteriorated, they can actually send the ambulance in a preventive way to take it to the hospital and to take charge before it was too late. So the system is very well organized, and actually it proved to be a resilient component of our health system during the pandemic. Of course, during the pandemic, we struggled as every other country when especially Delta wave struck us, because the demand was overwhelming. I mean, we had to open like beds in every single alley. The hospitals increased significantly, but we never were on the verge of collapsing. Everybody got the care, not maybe in the best conditions possible, but everybody got the care that they deserved. This is a general scheme of how the system of healthcare is structured. I emphasize this, stress this, healthcare service. That is not the same, the healthcare service that the national health system, because the national health system comprises all the different actors. The stewardship of the ministry, the healthcare provider, but also the universities, the pharmaceutical industry, and also the other sources of financing we have. So the basic thing that is in charge of the sector that comprises around 4,000 people I mentioned, those teams are grouped into what I call Zoom that have all these different teams, but also a support team. The support teams have the dentistry, the nutritionist, the psychologist, the social worker, and sometimes a specialist in medicine, for example, internal medicine or pediatrics, depending on the needs of the particular area. That area is supported, as I told you, by a mild-sized clinic. And then we group these zones into a region, and those regions are supported by regional hospitals that have like a little more complexity of care than the clinics. And then the regions are meant together as a macro regions in the country that refer to the national specialized hospital of the third level of care. Okay, I will explain this. This is the support team in the basic team. The basic team is the physician, the nurse auxiliary, the primary health care technician, and the health record clerk. And the support team on the mild-sized clinics is the family doctor, the nurse, the social worker, the pharmacist, the microbiologist, the ontologist, the psychologist, and the nutritionist. Okay, other stakeholders, and actually reaching the end of the presentation already, that are part of the National Health Service and have a really key role. We have an institution called the National Insurance Institute. That is a very old institute. It was actually, it was created in the mid-1920s at the time. And the reason actually they were separated to the Social Security institution is because of that, it's history. They are older. And at that moment they were created, it was created with the idea to insurance people for two major risks. The traffic-related injuries that were starting happening at that time, 1920s, you know, they were the first road traffics. And nowadays, still, they are in charge of this. For example, every year in December, the owners of cars, we had to pay a tax to the government, and a specific part that tax goes to this institution to cover all the costs related with traffic injuries. Okay? And the other is the war-related injuries. That is an additional tax that all employers had to pay to cover the issues, for example, cut your fingers or develop a specific condition because of the work you do. They are covered. That insurance is the one that covered all the costs relating to the care of that condition. Even if you had to go into an early retirement, or for example, if you die during a war-related accident, the compensation your family gets because of that comes from that found that is pulled in that organization. There are another financiers of the system that collect money from special sources, and they either give it to the ministry to buy the services, for example, I mentioned with vaccinations, or they give the money directly to Social Security to finance specific projects. Sorry. The Ministry of Labor, for example, they collect a specific taxes that goes to, especially to finance programs related with childhood and disabled persons, for example, inclusion of disabled persons in workplaces, or the physical therapy or rehabilitation of people who acquire disabilities. The National Lottery Board, that here in Costa Rica, all lottery and gambling programs or games are owned by the state, and only the state can license certain special places like casinos or something like that, that they have to pay taxes to the government. This national board collects all the money and distributes it to social programs, for example, unemployment, orphanage, senior care centers, things like that. And also they give money to the Social Security to finance specific projects such as cancer care. For example, if you have an NGO who want to provide, I don't know, like a new CT scan to a hospital, you can develop a project and add the money to the National Board of Lottery, and the project is reasonable and they have the money that year, they can allocate you to buy that equipment. It's like that. There are many other things, but that. the Ministry of Finance, I told you, and the National Emergency Fund, that, for example, I told you that was the one who financed the acquisition of COVID vaccination. And we have a private market, a private sector, that is comprised by the individual medical practices. So you have, you can work both, for example, for the Social Security in an office schedule from 8 to 5 or 7 to 4. And then after that, you can have your own practice, or in weekends, you can work with them. Pharmacies, laboratories, long-term care, private hospitals, wellness center, that actually is something that is becoming a very important sort of income for the country, for all the medical tourism industry. There is so many people coming from the US and Canada, well, maybe not Canada that much, but also other places, to receive medical care here that is actually cheaper than you can afford in the US, especially like dentistry or plastic surgery or reconstructive surgery, with a quality of care that is comparable to the US, because many of the insurers that work in the US require, for example, the private service facilities here to be accredited by, for example, Joint Commission, JCI, and many, I think practically all private hospitals here have the accreditation for JCI. So that gives you a certain warranty assurance of quality of the services to a price that is far considerably less than what you could pay in the US or other places. And that's why actually private sector is becoming more and more aware of the systems here, and actually playing a more important role here in the country. And nowadays, because of course, I mentioned, public facilities are good. They provide lots of services, but they're not perfect. Of course, long waiting times. If you need a surgery for something that is not an emergency, for example, removing your gallbladder, maybe you can face a list of, if you're lucky, maybe a year. On average, maybe 2 years, depending on the hospital have to take care of you. And many people actually, now that we are, like, as I mentioned at the beginning, an upper income country, many people have access to private insurance. For example, many international companies, Amazon have most of their customer services facilities here in Costa Rica. So when you order something in Amazon in the US and you have to speak with Kevin from customer support, probably Kevin is a Costa Rican. And he's not changing his name is Kevin. So Amazon, as part of the benefit package they give to their employees, they have like international insurance that can cover this kind of thing, like going to a GP consultation or maybe a minor thing, but they're not going to cover you, for example, cancer or any really expensive thing. But that actually have made that private sector grows here, not only for tourism coming here to get a cheaper price, but also to locals who want to like avoid long queues at the Social Security, things like that. Okay, that's the end of my presentation. I just want to, you want to actually learn a little more about the history of our system and how actually it's developed today and how it's working today. I recommend you this article that actually was published on the New Yorker last year. It was a very comprehensive article. It was an interview that someone there, a journalist from the New Yorker, made to a former leader of the National Social Security Service. It's really, really interesting because it's an interview given from his own perspective, but also they visit like facilities in the country, and they explain how it works. And actually, it focuses a lot how it works during the pandemic and how the system as a whole managed to cope with many of the necessities during the pandemic. So I can give you the link. I have your email address, so I can send it together with the presentation. And I would like to finish playing a video, a short video about, it's an introduction actually of a series of 10 videos that I recommend you can go through that and learn about this project that was taken care, it was run, by National Geographic Society, that they were studying different zones in the world where they found that people live really long and healthy lives. It was called the Blue Zones, and as I told you, was run by National Geographic Society like 10, 12 years ago. And it's really, really interesting because it's focused in this place called Nicoya, that is on the North Pacific area of Costa Rica, but it reflects, of course, that particularly because that's a place that was studied, but in many other parts of the country, you can also find these kind of communities that people, as I mentioned, live long and very healthy lives. So I'm just going to play that video, and that will be the end of the presentation. Oh, wait. Oh, there was. Sure. It's in English. Sure. Because it's the sound of the speaker, so it's not going. Let me see the capture. Yeah, it's in English. Don't worry, it's going to be.
What if I could show you how to add 8 years to your life, but not just add them, live them, stronger, happier, and healthier? That's me, Dan Buettner, Blue Zone's founder and expedition leader. Here at Blue Zones, we set out to explore cultures and study the people confirmed to be living the longest, healthiest lives. We gather their stories, uncover their secrets, and distill the results with you. We're not searching for a silver bullet or a magic pill. Instead, we'll present an a la carte menu of time-honored practices you can put to work in your own life right now. So far, we've investigated blue zones in Sardinia, Italy, Okinawa, Japan, and among the Seventh-day Adventists. All of these populations live about 8 years longer than the average American, suffer a fraction of the rate of heart disease, and have strong families and communities. Now we've come to Costa Rica's Nicoya Peninsula, home to the longest lived people in all of the Americas. With the help of demographer Dr. Luis Rosero, we've confirmed the ages of local centenarians and determined that middle-aged men have a fourfold better chance of reaching age 100 than we do in the U.S. Here we found the world's most amazing centenarians, like a 101-year-old man who plays the guitar, a 102-year-old woman who composes poetry,
aquella playa bendita, ya mi corazón palpita,
and her 100-year-old neighbor who still chops wood and wields a machete. This year's team of experts is one of the best we've ever assembled, a world-class group of scientists, journalists, and cutting-edge media specialists. The only thing missing is you, the most important part of our team. Each day, you'll vote to decide what we investigate and what we film. And at the end of the expedition, we'll list our findings and let you decide what discoveries are most important. In just a couple of days here, we've already uncovered some great leads. We heard about an amazing local diet that's 3,500 years old, about a philosophy of life called Plan de Vida, which may have some long-term psychological benefits. And the native Amerindian influence is greatest here, suggesting that genes may have something to do with Nicoya's longevity. These are just 3 of about a dozen clues we can follow, but that's up to you. So click the vote button and help us figure out why people here are living longer than any place else in the hemisphere.
Living longer, better. Blue zones.
Well, things happened. Okay, so that's only the introduction video. It's going to be there in the link. It's like a playlist in YouTube. But it's really interesting because they interview one person in every video. They make like a life profile of them and how they live their life. And one of the things that they found is not, that's actually why I want to show it. It's not related at all with the healthcare access. Now then, knows then,
Yep.
Gracias. Things happen. I was trying to say that none of them actually, you will see that they attend regularly to the healthcare services facilities. They actually live healthy lives because the way they structure the life. That's why I was actually stressing part of the conference that even though our healthcare services is really strong, it's really comprehensive, reaches the people, it's financed universally, it's not the key of why Costa Rica have the indicators it have. It's basically a way of how we have constructed the health vision of the country over the past decades that not only focus on the health services provision, but also on the health itself. That's why also the Ministry of Health does not provide health services, but also cares for all the aspects. So I leave you there with the information I mentioned are things that actually we can implement in our daily lives. So also I give you, well, I will give you the presentation, of course, and also the links for the article that explains very, very well how the healthcare systems works. And this will be so just learn a little bit more about our way of living. So that's all from my part. Thank you for your attention, and we are open to discussions and questions you have. Sorry, once again?
Earlier when you mentioned about the contraceptives and education, you mentioned that it was mostly geared towards women, and I was trying to figure out why was that?
Well, first of all, it's a really interesting question. I think it's part of the historical development because we were talking about 1960s. So in that moment, the culture we had it was pretty much similar to any other world. Any other place. Focus on men don't care about that things. Because women issues are women issues. And I think it's quite important because that actually shows you how often we at the health system had to deal or to cope with the mentality of specific groups or specific communities at that moment in order to actually deliver the care we want. At that moment, well, most of the women were housewives, they were at homes, and the person who actually attend to the healthcare service to take the children were women, because men were working. at the farms, at the factories, or wherever place they were. So that was part of the issue there. Nowadays, of course, women still have a very strong focus on maternal and reproductive health. Most services are, but of course now there are like facilities to men too, and also the health, the sexual and reproductive health programs at schools. They focus in all people attending, all the students, men, female, and not only thinking on reproductive issues about using contraceptive measures, but also thinking about health itself, sexual health itself. Even if you are not like a straight woman or straight man, it's like a little more comprehensive, of course, than it was in the 1960s. That's why I can tell you it was because of the time.
I had a question. So given that Costa Rica has a very solid economy, right? It's very stable, it's very solid, has a higher GDP per capita in comparison to the neighboring countries. Have you seen increased immigration coming from Nicaragua that is going through a very hard time right now, or from other countries in the Central America? And how has the immigration impacted the cost of healthcare services in Costa Rica or the quality?
Wow. How many hours do we have? No, I mean, first of all, quite important data. Costa Rica actually is a country right now in relative terms, in percentage, we have a higher immigration rate than the US. Because even we are, as mentioned, like 5 million people, around around 705,000 people were not born here in Costa Rica. So that's a proportion, and that happened in the last 20 years. So it's just like, for example, you're in the US, we are 300 million, something like that. Just imagine that over 5 years, around 75 immigrants come to the country. Of course, I know that the U.S. immigration is a huge issue, especially nowadays because of all the crises you have in the south border with the people coming from Central America and other places. But the issue is that many of those people actually come through Costa Rica because they start their migration path from Cuba or Ecuador or even Africa, from Colombia or Ecuador, and they just start going up north and they pass through. And some people actually stay here because they were denied to cross Nicaragua, or they cannot cross Nicaragua illegally, as many people are actually doing now. And many people are staying here. From the 1990s till the mid-2000s, most of the immigration were from Nicaragua, of course. Then it came immigration from Colombia because of the humanitarian crisis there. Then Venezuelans came. Then all these African people, Haiti. And even though nowadays most of the people, immigrants, are from Nicaragua, there are this all myriad of different nationalities, even intracontinental people coming here. I mentioned this just not because giving the interesting fact, but because also it puts a lot of pressure on the system, not only economically, but also culturally, because we are not accustomed to deal with people from different culture in that way. I remember for many years, dealing with Nicaraguans, it was really a really strong shock, because when we speak the same language, it's not the same language. Because the accent, the way they construct the idioms and things like that is different, and the way of living and the daily living is quite different. So how do you approach someone who actually is not from your same culture? It's quite hard. That actually had put a lot of pressure for us to develop programs to make it more cultural, assertive or accessible, and that has been a huge challenge. In regards of economic, That's actually part of the discussion. Every elections, all the candidates always ask about that, because there is, of course, many people who claim that these people are ruining the system because they are using the system for free, in the sense that they don't pay their taxes, they don't contribute in any way. And it's just partially true, because you could tell me, you asked me, like 20 years, 25 years ago, that was the rule, because all the Nicaraguan immigrants were illegal immigrants here. So they even work here, but they do not contribute. That had been changing. Many Nicaraguans had get like the equivalent you have in the US of the green card. So they can be like legalized, not only their immigrant status, but also they can go into the payroll. They can actually collect and pay taxes, which is very good, because, as I mentioned, we are getting an old society. So we are getting less and less people who contribute to the system. So if we take people from abroad who come to work, who come to produce taxes and revenue in general, that's good for the country. So, of course, they have been like shots to the system in terms of finance to provide care for people who is not insured, but they have been also like this, how do you say, like these new contributors, taxpayers, thank you, to the system that otherwise it will not be. So it's like a mixture. And every time that actually someone wants to get into a real objective discussion based on evidence, most of these stereotypes and all these prejudices and all these misconceptions usually come. Right now, there are so many people who say that these people is ruining the system, and the reason you had to wait for 2 years or 3 years for surgery because of all the Nicaraguans we are paying for free, which is not true at all. So, of course, it's a huge challenge, but a challenge that also had other variants. It's without all these Nicaraguan people, who are actually the people who is having kids. Those kids are being born here, so therefore they are Costa Rican. They're the ones who actually are sustaining demographically the country in some aspects, because otherwise we will be already an older society that we are becoming now.
We know from other countries that in order to sustain economic growth, you need to have a healthy immigration system. The same thing happens in Europe, where I grew up. The same thing happens in the United States. We need the immigrants not to live and come for free, but we need them to come and generate revenue and become good taxpayers, so they will help the economy of the state that they integrate in. So, but it puts a great strain on the healthcare system, because the healthcare costs will increase, and the challenges will be even, greater than before. But we know we need the immigrants. But I know the situation in Nicaragua is going to put strain on the Costa Rica economy and also the healthcare system. The same thing that happens in the U.S. with all the, immigrants that we see from other places.
Yes, definitely. I think also that the pandemic was really interesting, that it opened our eyes to a reality that we were denying for many years. What happened is that Costa Ricans, because we are becoming more educated, more middle class, we are rejecting certain kinds of jobs that we don't want to do anymore, because we relate them, associating them with like low income. For example, specifically agricultural tasks, collecting coffee, collecting other kinds of crops, construction, house services. What happened that I really like what you said, a healthy immigration system. We depend currently a lot to harvest the coffee on immigration force, but seasonal immigration. People who come here only for the harvest period of coffee that goes like only for half of the year, and immigrates through that. This is not the same season in all the coffee, in all the areas that produce coffee. So at the beginning of the pandemic, when we closed the borders, as many other places, we closed the border to everybody. 2 months later, when the harvest season of coffee was supposed to begin, so the instruction from the government was no one enters Costa Rica, period. So who is going to collect the coffee? The solution is that's perfect because everybody who lost their jobs because of the lockdown restrictions then can go now to the farms and collect the coffee. So perfect. Nobody wanted to do that. It's quite interesting. When I was a young kid, I usually spent my summers collecting coffee. There was nothing particular like that. Many people in my family did that. Absolutely no one from my family, especially my younger nephews and nieces, want to do that because it's associated with like precarious conditions or things that are left for the immigrants, not for us. We are not we have some racist company in our country. That's not something we're really proud of that, but it's a reality that happened because we have this sensation we're like better, in a better position than other countries, so we don't want to like downgrade ourselves. That's not nice at all. That's not something to be proud of at all, but it's something that happened. So what happened at the end? It was so much the pressure because we were going to lose the harvest of coffee and then other crops like pineapple and banana that we had to open the borders to those immigrants who were also not only come here because they also represent a huge impact on the local economies of those communities, on the supermarkets, on the coffee shops, on the facilities that rent the houses, where everything around the coffee plantation depend on the immigrants coming every year and spend the money there. Also, they will take some money, of course, back to Nicaragua or even Panama, but there is so much money that is left here in the country that otherwise, I mean, the economy will suffer strongly. And also, that happened that if the economy moves, new jobs are also made at the supermarkets, at the restaurants, whatever, and that means also more income in paid, in payroll taxes to the Social Security. So it's a circular economy that depends a lot on immigration. But as you said, healthy immigration system is the key. We have a strong reformation of the immigration system like 10 years ago, actually to cope with our current needs. And actually, as I mentioned, I think that immigration law are right now more strict than the US because of the need we have, but also on the problem we have in the previous years. Like, for example, till that reformation, if you want to obtain the Costa Rica citizenship, you can marry a Costa Rican, eventually in a couple of weeks or months, you get the citizenship. But the law allows at that moment that you were, it's called married by proxy. So you're someone in Cuba, you are in Cuba, you sign the paper to give the power to someone to marry you on your behalf to a Costa Rican, even if you never met. Yeah. So that was abolished, obviously, because they were giving a lot of problems. Because you don't know who were you marrying, but and you were not married. Someone was marrying you on your behalf. And that was legally. And of course, that was something that happened like many, many years ago, that the law who opened that possibility. But of course, that was abolished because that was giving a lot of problems, not only because of immigration, but also people who were running for authorities in their countries or trying to renew their life, things like that. So we made a really strong reformation of our immigration system. Like, once again, it's not perfect, but it's far better what we had before. And actually, it deals a lot with that, with our current needs, because we were not as a big welcoming or receiver of immigration that we used to be like 30 years ago. And we depend now a lot of not only permanent immigration, but also seasonal. And actually last year, a new law was adopted to also welcome, I don't know yeah, digital nomads, you know the concept? People who are commuters or teleworkers who move 6 months in one country, they go to 6 months to another country, just moving around the world permanently. And they never settle in one place because they can do their work from anywhere in the world just using their laptop and a good internet connection. So a new law was approved to welcome these people in Costa Rica to just come, yeah, live in Costa Rica for 6 months, live all the money you want here and consume, because we need this new kind of income. And even they are not going to be like contributors to the social security directly, because we're not going to collect taxes to them. The money they bring will allow to actually create new jobs and new incomes that can go eventually not only to social security, but all to the government organizations in general. Any other question? Well, thank you very much for your attention. I know it was a lot of things to process in 1 hour and something, but I'll leave you the I will send you the presentation and the links, so you can learn more of that. And you have any other questions, you can just text me or write me to my email. Thank you very much, and really have a very good tour these days here.